of the esophagus. I have two lectures with you today, inshallah, and on Saturday it will be the second lecture. Don't forget, I will give you also the subject of the cardiac surgery and vascular. Today we have another lectures with you about the heart surgery of the heart in the 12 o'clock to 1 o'clock. And in the next week, on the Saturday, we will start the esophageal surgery. Now, today we will discuss what is the surgery of the esophagus. First of all, you should be known any part of the surgery, the embryology, from where it comes the esophagus. The esophagus is also developed from the foregut, which started gradually to the larynx from the 7 weeks of the gestational age, and there's start of separation between the trachea and foregut, esophagus, by symptoms, and this is initially when it comes, it will be obliterated, the foregut, the esophagus is obliterated, but it will be open in the 8 weeks of the gestational age. The upper part of the esophagus is contained striated muscles, and lower part contain the small muscles. Now, what is the anatomy of the esophagus? If you remember it in the anatomy in the second year you took it, it contains of the mucosa and submucosa and the muscularis, which is contained of two muscles. It is a circular one, and the outer one it is a longitudinal, and there is an adventitious serosa that it will be covered the layers of the muscles. And as you see, there is a three part of the esophagus. We have in the cervical part, and we have a thoracic part, and the abdominal part, which is the most important one. It is a intra-abdominal part. The length of esophagus is different from 1 to 1, but it is normally it is a 25 centimeter in length. The upper part, if you took it from the incisor teeth to the first part, it will be 15 centimeter, and this is, it will be come from the vertebra, cervical vertebra 6 to the thoracic vertebral 1. It will contain about, the length of that one, 3 to 5 centimeters. The thoracic part, it could, and it started from the T1 ila T10. This is, we have also abdominal part. The abdominal part starts from the thoracic 11 ila thoracic vertebra 12. The length of that one, it is about 39 ila 48 centimeters. And we have three constrictors in the upper part, in the esophageal, in the cricoid cartilage, and also we have in the aorta when it crosses with the bifurcation. It will be also, there's a neurostenosis of the esophagus, and in the cardiac part, this is what we call the lower esophageal part junction. Also, this is a constrictor. As you remember, this is the diaphragm. We have three holes in the diaphragm. The inferior vena cava, it will be at the level of the T8. The esophagus, it will be at T10, and the aorta, it will be at the T12. The blood supply of the esophagus, it is the most common part. It is good blood supply. It is the cervical part, and the lower part, the abdominal. The poor one, it is the thoracic one. The contain the upper part from the inferior thyroid artery and the drainage in the vein, and we have two accessory azygous vein and hemiazygous vein. We have, this is a vein supply of the thoracic part, and also we have in the abdominal part, we have what we call it from the short gastric veins and short gastric artery contain of that one. This is the arterial one, Get it from the inferior, And also, if you remember that, now the physiology of the esophagus, how it will be the swallowing. The swallowing, it will be in the sixth process. First of all, it will be elevation of the tongue, posteriorly movement of the tongue, and elevation of the soft palate, and elevation of the anterior movement of the hyoid bone, and elevated of anterior movement of the larynx, and tickling of epiglottis. It will be go easy to the esophagus instead of going to the trachea. Now, the most important now, it is in this surgery of the esophagus. Today we'll discuss a part of it, and the next lecture, I hope that, inshallah, we discuss the other part of it. Congenital anomalies of the esophagus, a foreign body swallowed, and surgical achalasia with diverticulum and hiatal hernia, surgical of the reflex esophagitis and esophageal tumor. I think you remember by Dr. Father, he took a medical part, and we will take a surgical part of this part of the esophagus. Now, the congenital anomalies of the esophagus contain 4 parts. The most important, we have a tracheoesophageal fistula with or without atresia. Second, a short esophagus. Third one, an esophageal stenosis. And fourth one, it will be dysphagia disorder. Now, which is the most common one, what we call it, the tracheoesophageal fistula and esophageal atresia. We have 6 types of these anomalies, which is a more common type. It's what we call it the A type. But in A type, it will be have communication, a distal part of esophagus with the trachea. The upper pouch, it will be blind. Or we have, there is no communication between trachea. We have an upper pouch blind, a lower segment also blind. Or maybe you have only the H type, only we have communication between an esophagus trachea without atresia. Or maybe we have 2 communication in the upper part of esophagus and lower part of esophagus to the trachea. Or in opposite to the common type A, the upper pouch are communicated to the esophagus, to the trachea, and lower part it will be blind. Or maybe you have this is a short or a stenotic part of the esophagus. Now, what is the more common site that we suppose this baby have this anomalies or not? How you can know? But first of all, by the history. When you took the history from the mother said we have a polyhydramnios. Polyhydramnios mean a big abdomen, a large of fluid in the uterus. Why? It is a high fluid in the omentic fluid. Why we have? Because the baby always he drink this and swallow of this amniotic fluid and secreted by the bladder. I mean, there's a complete circulation from the swallowing and evacuated by the urination system. Any blockage in both sides, either in the difficulty in the swallowing or there is an obstruction with outflow by urinary bladder, it leads to the polyhydramnios. Second, when we have this, the baby it will be have pouring of saliva from the nose and the mouth. When the start of the feeding by the mother, it will be pouring of this milk start coming from the mouth or from the nose, and it will be put it in your mind. Maybe there is an esophageal atresia with tracheoesophageal fistula. To confirm that, you took a chest X-ray. Chest X-ray, what is important? Because we want to see if there is a gas in abdomen. In abdomen, always there is and the fundus of the stomach, we have a gas. This is very important to diagnosis if there is a communication to the trachea or not. Because if there is no communication with the trachea, there is a blind distal part, there is no gas in the abdomen. And To complete sure that you are have these anomalies, you put a nasogastric tube, a catheter 10 size in the French, and you can inject it a contrast material with this to confirm your diagnosis. Always when you have these anomalies, you should be search about the anomalies associated with the tracheoesophageal fistula with a tracheal atresia or esophageal atresia. This is what we call it vacuole. What does mean the vacuole? V mean there is always maybe associated a vertebral anomalies like a spina bifida. A mean anal stenosis or anal anomalies. C, there is a cardiac anomalies, either a common one is a dextrocardia we have or VSD. And TE, this is tracheoesophageal fistula. R mean a renal problem, renal, and there L mean a limb anomalies, either in the hand or the feet. Short esophagus occur due to the hiatal hernia or due to the reflex esophagitis. Nobody know. The cause is either due to hiatal hernia or due to the reflex esophagitis. Second one, it is a third one, sorry, it is an esophageal stenosis. It can occur any part, either it's the cervical part of esophagus or maybe in the thoracic part or maybe in the lower part of the esophagus. What we mean by dysphagia disorder mean there is a normal esophagus, but it will be compressed by anomalies. Either we have a double aortic arch or maybe have abnormal insertion of subclavian artery. This is the contrast that we see. There is an air in the upper, in the air, and there is a blind one. This is a contrast to see there is an esophageal atresia and there is a distended upper pouch. This is a catheter that we inserted to show for you. This is the upper part, it is a blind upper part of esophagus. It is a blind mean there is a tracheoesophageal fistula and there is an air in the stomach. If you see it, mean this is the common type. It is an A type. In the upper part of esophagus, it is a blind pouch, and the lower part of esophagus is communicated to the trachea. This is the most important one, and this is what we see in the anomalies of the lower limb of the baby, and the upper limb. This is a radially one aplasia, what we call it. How you can treat it? This one we can treat it by many methods, either by one-stage operation or two-stage operation. One-stage operation we can do it by thoracoscope or by open cut by thoracotomy. Always we use a right side thoracotomy. We can do it, and we can do anastomosis. First of all, you should be cut the fistula from the trachea, and you should be mobilization in lower part and upper part of the esophagus, and you start to do anastomosis. As you show in the picture, this is for your knowledge. It is not important to know the surgical procedure. This is how we can do it. In other, we have this is what we call it an H type. In H type, always it's common in the cervical part of esophagus. The presentation of that one, the presentation of the H type, it will be delayed, not like in other part of the anomalies. It will be start either in the first day or in the first week of the neonatal age. Why it will be presented? Because it will be difficulty to eat. It will be they have regurgitation of the materials that he took it, either artificial milk or the breastfeeding, and beside that have a chest infection, because if there is a communication, between the trachea and esophagus, maybe you have gastric juice, it will become to the trachea, it will be lead to the chemical pneumonia. If there is an upper part communicated to the trachea, it will be lead to the aspiration pneumonia, and this is the presentation of these anomalies. This is by thoracoscope how you can do it. And this is we show it in how we can. It is in H type. In H type, there is a communication between the part of the contrast going to the trachea, and in esophagus, it will be continuation from the mouth to the stomach. Now, the second important thing is that it's a foreign body. Always the baby, it will be curious to discover the surrounding part of it. Any part, anything in the hand, they put it in the mouth, And this is, it will be, have either the foreign body, it will be stopped in upper constrictor at the distance of the 15 centimeter from the incisor at the cricoid area, or maybe it will be settled in the 25 centimeter of the incisor at the part of the aortic arch or bifurcation of the trachea. This is another constrictor, or maybe you have in the lower part of the esophagus and the cardia. Here, how you can diagnose the baby, it will be a start. It is not just a baby, maybe in adult also we have a difficulty, especially in old age, have a dentletless, and there is no teeth. Start to when eating, it will be took a part of the bolus of the meat. It will be also settled in this constrictor lead to the foreign body swallowed. And diagnosis by the chest X-ray and 2 view always, and the chest always don't forget to take 2 view, a BA view and lateral view, and the treatment by the endoscopic. Here you should be put it one thing, you should be remember it, my dear student. If there is a swallow of foreign body in the adult, especially a meat or anything, when you remove this foreign body by esophagoscope, by rigid esophagoscope, or even by fiber optic esophagoscope, don't forget after that you should be took a biopsy, because there is a constrictor, maybe there is an underlying esophageal tumor. This is in adult, especially in adult old age, where there is any settle down of the foreign body in the constrictor. You should be remove the foreign body, and you should be took a biopsy to exclude underlying pathology of esophageal tumor, but not do it in the baby. Now, another important that we can face it, what we call it a cardioplegia, a cardiospasm, or what we call it achalasia. We have a cardiospasm achalasia of upper part of esophagus. Maybe you have a lower part of esophagus. Don't forget, if there's any questions in the exam, I told you about a cardiospasm, mean achalasia of lower part of the esophagus, or maybe I told you achalasia of upper part of esophagus. You should be differentiated in this term. A cardiospasm mean a lower part in the cardiac area, cardiac and lower part of esophagus. What are the causes of that one? Of the achalasia? Mean there is a failure of relaxation of lower esophageal end. When there is a failure of relaxation, mean there is an abnormality. If you remember it, there is a 2 nerve supply in the esophagus. What that we call pulmonary. This is between mucosa and the muscle, and between the 2 layers of the muscle, what we call Orbach plexus. When there is a deficiency or absent or less nerve supply, this is a congenital one. This is lead what we call it to the achalasia. It will be a spasm of lower part of the esophagus. By the time, if you have any obstruction distally in the upper part, what will happen? It will be lead to the dilatation. Dilatation, it will be because of the esophagus, lead to the tortuosity. And this is in coordination of the peristalsis with hypertrophy of lower esophagus. Sometimes what we call a sigmoid esophagus. It will be the esophagus, a diameter of esophagus. It look like a sigmoid diameter of the lower part of the colon, like the sigmoid. We call it a sigmoid esophagus. This is an uncommon, but it can occur any age. Mainly, we can find it in the third decade. Female, it is more common than the male. It is a 3 to 2%. The etiology may be idiopathic, or maybe the loss of the ganglion in the cell, what we call an Auerbach plexus, either due to the congenitally or maybe due to the neurotropic virus. This is what we call the Varicella zoster. Or maybe in Chagas disease. This is due to the Trypanosoma cruzi. This is more occur in the North America, that one of the Chagas disease. Or sometimes this is what we call a pseudoachalasia, due to the tumor compression of the esophagus, or due to the hematoma, or maybe to the enlarged lymph node that to lead to the compress of the lower part of the esophagus. Now, how it will be presented of that you? It will be dysphagia in 98%, regurgitation 75%. Don't forget to differentiate it between two terms, vomiting and regurgitation. Regurgitation means it will be expelled a material that in the esophagus. Vomiting means the content of the stomach, it will be regurgitated and it will be spilled out. Regurgitation means the esophagus, material in the esophagus, and vomiting a material in the stomach. You should be differentiated between regurgitation and vomiting. Besides that, there's a chest pain in 43%, and there's a weight loss about 58%. When we have this problem, may be presented for you a patient with the repeated chest infection, like you have, or a chronic aspiration. It will be occur in 10 and 30%, especially this aspiration occur when you have a delayed dinner and you go to sleep immediately after you take a dinner. It will be part of regurg enter to the respiratory system and lead to the recurrent pneumonia. Diagnostic of that one, you took a plain chest X-ray to lose any pneumonia, and you will be see an absent gas bubble in the stomach, and also beside that, maybe you see a mediastinal mass because of the widening of the esophagus, and by barium swallow, we see it will be like the end of this esophagus. It will be like a bird beak, مثل منقار الحمام. هذا حتى تميز بالباريوم swallow between the cardiospasm achalasia of lower part with the esophageal tumor. That one, it will be appear like a rat tail مثل ذيل الجردي زين, and shouldering of the esophagus. These should be differentiated between achalasia and the tumor of the esophagus. And to confirm your diagnosis by endoscopy, by esophagoscope, and the most important diagnosis of the achalasia by esophageal manometry. This is what we call the standard for diagnostic achalasia. I think it discussed by the Dr. Fadil the procedure of the investigation. This is how we can see it. The dimension of the esophagus from 3 centimeter, it comes 3.5 centimeter. And this is what we call a sigmoid esophagus. Appear like a sigmoid one. Now, how we can treat it, the achalasia? If it is a mild one, we can do it by the medical therapy by giving a nitrate or calcium channel blocker. And nitrate like the isordil, Angisid. The patient, it will be, he said, I have no heart problem. Why you give for me an isordil or Angisid? This is to relax of the lower part of the esophagus. Calcium channel blocker like the adult nifedipine, amlodipine, This is also, it will be benefit to relax of the lower part of the esophagus. Now they start to inject the lower part by the botulism, toxin, or we can do it by the repeated pneumatic dilatation, and this is our risk of the rupture, but it will be curative in about 75% to the 85%. But this is maybe it need a repeated of the pneumatic dilatation. For us, we can do a modified Hiller myotomy. This is by splitting of the longitudinal muscles and the circular muscles, dividing, and you should be keep intact of mucosa. This is should be from the start of the الأكاليزيا, the stenotic part, you go 5 centimeter above and 5 centimeter below, reach to the fundus of the stomach. This is the most important. We do it by myotomy. The esophageal resection in sigmoid esophagus, and we can do it if there is no benefit from esophagus because there is no peristalsis movement in the esophagus. We can interposition by the bowel. Now, diffuse esophageal spasm. هذا مرات هو يجون من المرضى يقول لك يا أنا عندي صعوبة بالبلع، يصير عندي وجع لما آكل على طول behind the sternum. It is due to the uncoordinated esophageal contracture. مثل ما تلقى لك الشارع بدون ترافيك لايت، العالم كلها مخربطه، فهذا نفس الشيء يكون بالاسوفيجاس يكون incoordination of the esophageal contraction. But nobody know why it occur. This is a pain in the chest and dysphagia, and diagnosis by manometry and the bioarm swallow. It will be corkscrew appearance, and treated always by medical. If there is a difficulty, you should be do a myotomy all part of esophagus. This is how it will be appear. Corkscrew appearance of this, corkscrew appearance of that one. This is diffuse spasm of the esophagus. Now, the esophageal diverticulum. Diverticulum means a pouch. Pouch occur in the esophagus, either occur in the upper part of esophagus, the cervical part, or in the thoracic part, or in the lower part of the esophagus. We have two types in the upper part. This is in the hypopharyngeal area. We call it Zinniker diverticulum, or in the epiphrenic diverticulum. This is in lower part. We have two types of the diverticulum. Either we call it true one, or we call it a false one. Most important, the Zinniker diverticulum, it is what we call it pulsion. There is a traction and pulsion. Pulsion, it is a false one. Traction, it is a positive one. False diverticulum, it will be pulsion. This is arising in the junction of the pharynx and the cervical esophagus in the area what we call it of the cheline triangle, and this is a relatively weak area in the posterior hypopharynx between the inferior pharyngeal constrictor and superiorly, and this is lead to the what we call it in the cricopharyngeus muscles inferiorly. Cause of it is not completely understood till now. Maybe there is a two potential causes, possibility of that, either an increase of the hypopharyngeal pressure accompanied by the poor upper esophageal opening, or by a cricopharyngeal incoordination. There is a two possibility, either the pressure is high in this area with the obstruction lead to the pouch and pulsion of this part of esophagus, or maybe incoordination of the movement of the cricopharyngeal muscles lead to the false pouch appearance. This is what you call it a Zinniker. Now, clinical presentation of diverticulum. This is always occur in advanced age, يعني above 40 years and above, it will be presented with the complication of the cervical dysphagia. يقول لك والله عندي صعوبة بالبلع في رقبتي. يعني من فوق يقول لك دكتور، يقول لك من فوق، يقول عندك في رقبتي، يقول عندي صعوبة بالبلع، ما أقدر لكنه كل ما أريد آكل، يعني زين يصير قسم من الأكل أذبه أطلعه، فيكون عنده what we call regurgitation of that part, and it will be a feeling of the globus. يعني يقول لك والله أنا كل ما أحس أعبالك إنه فد ورمة في رقبتي، فد ورمة شيء ضاغطة على رقبتي. This is what we call the globus sensation, and always we can feel it in the left side of the neck, because of this pouch in the upper part or cervical part of esophagus. Maybe material that contain in that pouch, sometimes it will be lead to the inhalation to the trachea and lead to the pneumonia. If there is a small diverticulum, maybe it will be asymptomatic. And if you do a screening for the old age with the difficulty in the swallowing, maybe you find a lot of them have a diverticulum, a false one, Zinniker type, without any complaining. A diagnostic by barium swallow and by oesophagescope. And this is the pouch, we can see it. And this is in the Zinniker type of the diverticulum, but we see it in the lateral view. And the treatment always, it should be if there is a complaining, a surgery, because there is no place for medical one here. Always when we have this diverticulum, we have two type of the surgery, and you do two procedure at the same time. I do it resection of the diverticulum, and beside that I do myotomy above the diverticulum and below it. Should be always I do the myotomy. And beside of diverticulectomy, I resected of the diverticulum, I should be do it. Otherwise, maybe it will have a recurrent rate so high if I not do it a myotomy. This is either by surgical or by endoscopic myotomy, you can do it. In mid-esophageal diverticulum, this is what we call it. That one we call it pulsion. Now we call it a traction. Traction means a true one. Something that attracted of the diverticulum. This is due to the either inflammatory process or scar adherent to the esophagus, lead to the pull of the wall of the esophagus from its natural way of the courses of the esophagus. And the middle one, we call it a traction through the upper part, the lower part, we call it false. It is due to the pulsion. دفع هنا سحب. Pulsion diverticulum arises in the mid-esophagus. Result of the esophageal motility disorder that lead to the area of high pressure and diverticulum with the mucosa protruding through the esophageal wall. لكن more common it is a traction. But also can occur in the mid-esophagus, also a pulsion, but more common traction. Remember in your mind, the traction is more common than pulsion in the mid of esophagus, not like in the upper part or lower part of esophagus. Clinical representation of that one. If it is a small one, always maybe asymptomatic. Otherwise, maybe have a dysphagia or chest pain, complaining of that mid part. It is so rare. So always maybe it's nobody is come for you in the mid part of the diverticulum, but always in the upper part of the esophagus, the lower part of esophagus, they always searching for medical advice. Diagnostic always, as you remember, by the two method, by barium swallow, and we can do by the cervicoscopy. Treatment, if it is asymptomatic, leave it. Don't tell to this patient, maybe he's nagging always, he said, I have this problem. Don't tell the patient that the patient have this problem. Otherwise he will be make a headache for you. If there is a large one asymptomatic, you should be do a diverticulotomy and myotomy. Don't forget two procedures. Myotomy is very important beside diverticulotomy. Another important one is epiphrenic, epinephrenic diverticuli. This is a pulsant one that is also an uncommon, but it occurs in distal part of esophagus, about 4 to 10 centimeters distally to the thoracic esophagus. Etiology of the epinephrenic diverticulum associated with underlying motility disorder, maybe associated with the chalasia. This is a more common causes of this diverticuli with the chalasia, or due to the diffuse esophageal spasm that it show the crook-like like appearance, and this is have sometimes due to the reflex esophageal lead to the part of the peptic secretion coming to the lower part of esophagus, and may be associated with the hiatal hernia, and hiatal hernia may be associated with the diverticulum. So many causes of the epinephrenic diverticulum, either due to the chalasia or hiatal hernia, or due to the esophageal spasm, diffuse esophageal spasm. Clinical of this also may be asymptomatic if it is a small one, but if it is a big one, maybe have dysphagia, regurgitation, and chest pain. It is a variable degree of this according to the size of that one. Maybe lead to the esophageal obstruction, or sometimes lead to the perforation and fistula formation with the lung, with the pulmonary system. This is a bigger problem. It should be dealt with them. Diagnostic, as we remember, the most important, we do a barium swallow and esophagoscopy. Beside that, we do an esophageal myotomy. This is how it will be appear of the epinephrenic diverticulum and the lower part of the esophagus, Sure. And this is how we can see it by endoscopic. It is a small opening of this by endoscopic lead to the diverticulum. Treatment of this, it will be directed and associated to remove the disorder of the motility. The most important, in myotomy, don't forget it, I repeated in myotomy beside of the diverticulum. A non-surgical option are reserved for the patient with the chalasia and epiphrenic diverticulum. Both may be benefit from the botulism toxin injection, especially if associated with the chalasia with lower part, or maybe it's benefited from the pneumatic balloon dilatation. This is if you have two things, and diverticulum beside the cardiospasm achalasia, maybe it is a benefit by non-surgical one. Otherwise, if it is a big one, symptomatic, the surgery is the only options for treatment of that one. Thank you for your listening. If you have any questions, you can ask. And don't forget, I have another lecture with you today, inshallah, at